This podcast is for informational and educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Patients in need of medical advice should consult their personal health care provider.
From UPMC Children's Hospital of Pittsburgh, welcome to That's Pediatrics. I'm Carolyn Coyne. I'm a basic scientist in the Division of Pediatric Infectious Diseases.
And I'm Brian Martin. I'm Vice President of Medical Affairs here at Children's. For today's episode, we welcome Alejandro Hoberman. Dr. Hoberman is the President of Children's Community Pediatrics and also the Chief of the Division of General Academic Pediatrics here at Children's. His studies focus on acute otitis media in young children, including a landmark trial published in the New England Journal of Medicine, which demonstrated that the reduction of duration of antibiotics does more harm than good when treating ear infections in young children. Welcome, Dr. Hoberman.
Thanks for joining us, Alejandro.
Thank you.
So let's talk about ears. I have a son at home with an ear infection as we speak. And so I would like for you to sort of tell us a little bit about your journey into how you chose the discipline that you work on. And then also, of course, tell us a little bit about your research.
So I was 26, I think, and I was at Children's Hospital in Buenos Aires, Argentina, and I was the only crazy person with a pneumatic otoscope trying to teach myself how to do a pneumatic otoscopy and move the eardrums, which was described from the journals I was reading in those days. And Jack Paradise here in Pittsburgh and Ellen Wald and Charlie Bluestone was the one that most of the papers were from. And I was excited about trying to learn how to do this. And I wrote to Jack, and very interesting, he sent me a telegram saying that somebody was coming to Children's Hospital in Buenos Aires and he would interview me there, and invited me to interview with Alejandros in Buenos Aires, who was the head of endocrinology here in that day. And then I came for fellowship. And fellowship meant, I did know that when I was there, that I needed to do my own research studies. And there you go, Jack Paradise and Ken Rogers, my two mentors, started pushing me like crazy, which is the project you're going to be working on over the next 2 years. And I ended up working in multiple projects. I ended up doing work on urinary tract infections and otitis media. And I have always had that problem in my life. I was a little unfocused, and I was focused on two different areas. And I continued that over the years. So Sylvan Stuhl was another otolaryngologist here in those days. And Sylvan, who was a pediatrician before being an otolaryngologist, had this huge cart with a big Sony TV that they have in the OR, and a xenon light source and an auto endoscope. And he said, you can do a lot more good with this than we can in otolaryngology. Why don't you take it and use it to teach the residents? So we started gathering images, videos, and trying to use those in training pediatricians. And then we opened up an ear check clinic to see children on follow-up after an ear infection. And then we developed multimedia tools. And then we got a grant from the CDC to teach pediatricians how to do a diagnosis of acute otitis media and distinguish it from otitis media with effusion and no effusion. And then we got embarked on every single development of a new antibiotic that was coming in the market in the 90s and the 2000s. And then about 18 years ago, no more antibiotics had been approved for upper respiratory infections. Since then, I think 2003 or 4 was the last one that was approved. And everything else since has not resulted in an approval by FDA. So we got embarked on other studies since then.
And how has that change in the antibiotic development affected your pathway in the conversation in both your research life and also with your general pediatric colleagues?
So in my research life, I departed from being involved in a lot of what I used to think of it as Colgate research, like toothpaste research, determining whether Colgate is better than Crest and so forth. And I got involved in trying to determine, okay, what do we really need to use antibiotics? So we did a study in which we looked at kids with bronchiolitis, and we tried to determine, okay, do they have an ear infection? If they have an ear infection, are they viral or bacterial? And we tapped the ears of those 30-some kids, and we basically found that all had bacterial acute otitis media. So then we started thinking about, we need to do a randomized placebo-controlled study to try to determine the benefit of antimicrobial treatment. And in the mid-2000s, 2004 or 5, we got funded by NIH to do a randomized placebo-controlled study. And that one we published, I think it was 2011 in the New England Journal of Medicine, and we showed that providing antimicrobial treatment not only resulted in substantial less treatment failures, but also there was improvement with regards to symptoms. So we were able to show both that the abscess, the bulging eardrum, was likely to be gone if you received a proper antibiotic, but also the child got better faster. So then we went on, okay, how long do we have to treat? Do we need to treat the 10 days of treatment? The goal is always to use the minimum amount that you need for any kind of condition. And we didn't know whether 10 days were needed. And a lot of folks were reporting about using 5 days of treatment. And then we went back to the NIH and got funded to compare 5 versus 10 days on a broad agency announcement that took us many years to do. And we randomized there 520 children. The goal was 600, but they stopped us early because they thought we answered the question. So they didn't want us to randomize anybody else. And we showed that, 10 days made a difference compared to 5 days. 5 days resulted in twice as many treatment failures. So the advice, Caroline, to you and your son is 10 days to go. Complete the treatment, because the likelihood of having a bulging eardrum is going to be a lot less.
I'm obviously in infectious diseases, and so this is something that I care a lot about and think a lot about. And of course, this idea of antimicrobial resistance and what a problem this is just globally in many, many aspects of healthcare. So I'm wondering if you can talk a little bit about that. It's obviously a big concern as you're discussing what you mentioned before, which is, I would say, viral versus bacterial ear infections, how you distinguish those, and then sort of what the adverse outcomes can be if you sort of prescribe antibiotics for obviously an unnecessary viral infection.
You are absolutely correct. I think the key point is, when do you prescribe the antibiotic? Mm-hmm. And it's once you do have a bulging eardrum, where you are seeing the middle ear is the only place in the body where you can actually see the abscess. You cannot see it in the lungs, you cannot see it in the sinuses, you can see it with the otoscope in the middle ear. And you can determine outcome by looking at the abscess and seeing if it's gone or not. And I would say we can do a lot more in decreasing the emergence of bacterial resistance by actually diagnosing the condition accurately and making the effort to distinguish those who are just having a little bit of fluid that doesn't need to be treated, that doesn't cause any harm. My mentor, Jack Barrett, showed that it doesn't make you less smarter to have fluid in the ear, and it doesn't make you talk slower if you have fluid in the ear. So we know that basically we don't do much about middle ear fluid. But if it's infected and it's an abscess and it's bulging, those children we have to treat, particularly if they are young. The American Academy of Pediatrics had the guideline committee, and we had, I was part of that committee. We had huge debates. But if you focus on the children under age 2, who are the ones that are most likely, that's where the peak incidence is of otitis media, between 6 months and 24 months, those benefit from antimicrobial therapy. And then using the right antimicrobial therapy is important. To use amoxicillin, when guidelines are very clear on that, amoxicillin clavulanate when that fails, and ceftriaxone. And there is no room for azithromycin, there is no room for ceftinir, there is no room for those medications unless in the truly penicillin allergic patient, who we know there are not that many. We label a lot of children as having penicillin allergies, but they not always have penicillin allergies.
I'd like to come back to the sensitivity and diagnosis, which you just spoke of. Can you share with us some work which you're currently doing or others are doing that's complementary to your work in terms of assisting those who diagnose middle ear disease and in improving the quality of our diagnosis, which then obviously feeds downstream to our therapy?
Sure. So I'm getting to the point, after having done 20 years of developing multimedia tools, web-based, CDs, write chapters and participate in guideline committees and write about these things. Sometimes we get to a ceiling effect of how good could we be at diagnosing otitis media. And I would say when we refer patients from practices or from urgent care centers, emergency departments sometimes too, who are diagnosed as having an ear infection. Many times they don't have an ear infection. They just have fluid in the middle ear. So the variability in the diagnosis of acute otitis media is high. So we'd like to try to assist and develop diagnostic aids. And over the last few years, I've been working with folks that were at Carnegie Mellon University. Jelena Kovacevic, my colleague, was the head of electrical and computer engineering at CMU, and now actually she just departed, and she's now the dean of computer engineering at NYU. So, and she and I are still collaborating, and she is the queen of classification algorithms. And she taught me that we can teach computers how to do the same things that we do in our minds once we diagnose otitis media. So Nader Sheikh and I and others and Jack Paradise have worked on developing algorithmic thinking on how we think when we go look at an eardrum. And the key point is there a bulging, yes or no? If there is bulging, we're done. We don't need more things. If there is no bulging, if there is opacity of the eardrum, it could be middle ear effusion, or it could be, those are the things that we consider in general. And if not, it's a normal eardrum. So the American Academy pushed to even make on the latest guidelines from 2013 that a red eardrum does not constitute sufficient to diagnose acute otitis media. So a viral illness can give you a red eardrum, unilateral, doesn't have to be bilateral, and we don't treat those patients. So if we restrict to treating those who are truly having a bulging eardrum, we can do a lot of good and decrease the likelihood of resistance. Going back to Jelena, the engineers are the ones that design these systems that classify blood cells or tumor cells or whatever it is. And she applied the vocabulary and the grammar that we think once we look at eardrums to the way they interpret images. So we created a system that actually creates an automatic segmentation of the eardrum, removing the ear canal, and uses 8 additional features that actually classifies them into 3 categories: normal, effusion, middle ear effusion, otitis media with effusion, or acute otitis media. And the system is close to 90% accurate. And we compare that with what we get with pediatricians, and where usually variability is at about 80% the best. So the system works very well. We're now doing video captures. We developed an application for the iPhone, and we are actually using an endoscope coupled with an iPhone to capture video images. And with the video images, we get hundreds of images, not just one image. So if there is a little wax occluding on one area, we can view the next images that will allow us to do that. And reapplying all those features to those video segments that we're collecting now, and hope to incorporate it into a grant we're submitting to NIDCD, Deafness and Communication Disorders Institute, looking at clinical decision support in the emergency department, in the pediatrician office, to actually look at can we aid in the diagnosis of acute otitis media by providing the answer.
Well, I'm wondering how that sort of, again, I'm not a clinician, but, how does this sort of misdiagnosis occur? Is it sort of a lack of understanding of the diagnosis, of the definition? How does that come about?
I think it has to do with the misdiagnosis is generally in babies. It's not on a 5-year-old complaining of ear pain. Those are easy. If you can see the eardrum and the wax is out of the way and you can visualize the eardrum, the 5-year-old is simple. The baby is a moving target. So you have cerumen, small ear canals, cerumen that partially obstructs the ear canal. And then you are relying on really subtle visual findings that occur in a brief observation of the eardrum. And I think that's the catch, that sometimes in the most experienced eyes, a brief observation may be all that you need. But not everybody's at that level, and it's very hard to really get to be sure that you saw enough of an eardrum in order to make a judgment there.
Especially in a crying infant.
Correct. Where you don't have sometimes the best holder, where the parents want to hold the child in their arms, and you really, in order to do a good exam, you've got to hold them on the examining table and get somebody to get a grip of the head and a grip of the arms. That you are using that you're using the right otoscopes, they have the right bulbs with the right amount of light. That once we get old, we start needing reading glasses, so we need to switch to otoscopes that have double diopters, so you can.
With all of these things, it makes 80% accuracy sound like
correct.
Pretty good.
Pretty good.
pretty darn good.
Pretty good. Do you see, Alejandro? Do you see any role with the kind of the emerging technology focus here on the diagnostic side for this to also aid in shared decision-making and communication with patients and their families in regards to the situation. And the reason I ask is because if we think about the retail medicine trend and consumerism in medicine and the, for example, in my clinical world, sometimes people show up with a Google diagnosis that they in their head that they've done at home, and they have made a decision that they want X, they want an antibiotic, or they want a particular prescription. Any thoughts about how this can also assist in talking, or do you ever find we have to sort of talk parents out of antibiotic therapy if it's an otitis media with effusion where we don't have an indication for an antimicrobial?
Absolutely, yes. And I think it has a dual purpose too. So it's on the parent side and the trainee side as well. So you get a tool that allows you to make it easier on the parents and the children, because you can go in with a device like this with the application and the endoscope. You can capture a segment of video, and then nobody else has to go in and look at the child again. You have the video to discuss with the trainees, or to consult with somebody else, or to use it in telemedicine application if you need help. So we're deploying actually at 3 offices. One at South Hills, in the South Hills of Pittsburgh, another one in Coudersport, Pennsylvania, at a rural qualified health center, federally qualified health center, and a third one in the north in Cranberry, Pennsylvania. And we have it at the primary care center with us as well. So we're deploying this, and we're using it for training purposes, and we're using it for parents' purposes too, where the parent can see what the eardrum looks like, and we can justify, here is why we need to use antibiotics. This is an abnormal eardrum, this is the bulginess, and this is what we want to try to make better. In contrast, when it's completely normal and the parent wants antibiotic, we can say this is why we don't want to use antibiotics, because when it becomes infected like this one, let me show you a picture of what represents a video of an ear infection. When it looks like this, then I want the antibiotics to work. And the parents are very responsive to that approach.
Yeah, as a parent, I would love that. I always, I'm probably a pain in my pediatricians because I always want to know why. Never. What virus is it? What is it? And so, as you were talking about before, sort of the bulging eardrum is that, I mentioned my son sitting at home with an ear infection. I've never seen what that looks like. And so for me, that would actually help me understand a lot of even the symptoms and the causes, and perhaps just because I tend to be a little bit more scientific in sort of thinking, that would be a wonderful asset and tool to have. And then in talking sort of about the parents, compliance, this idea of, again, antibiotic resistance emerging because, as you said before, you showed, very nicely that you needed a 10-day course of antibiotics to sort of get maximum effect. But, what do you tell, people that aren't really compliant to that? That, after 2 or 3 days, fever comes down, symptoms go away. The parent may say to themselves, "Oh, I don't need to keep dosing. Why do I need to keep giving an antibiotic? Clearly, the symptoms have gone away." And so, what do you see as sort of even ways to either address that or the potential problems that causes?
So we generally share the fact that we now have the data of the 10-day improvement over 5 days of treatment. We even did another study recently in which we were looking at a reduced concentration of clavulanate, and we actually looked at kids at 7 days to see if can we get between 5 and 10 and still accomplish it. And we got 2 observers, myself and Marian Harlam, our best nurse practitioner, who trains all the residents, by the way, and is outstanding at examining ears. And to commit ourselves, would we stop treatment at 7 days, even though we were not stopping for the study? But do we have enough improvement that we could stop treatment? And the answer was no. In most children, we would continue treatment. 60% of the kids, we would continue treatment. So we even gave up on the 7 days, which is something that the Finnish have used in their studies. In older children, they have used 7 days of treatment. So I was thinking about maybe 5, no, but maybe 7, maybe 8. But, I just stick with 10 days.
10 days is best.
Yeah. Right. And then one more thing that it's important too, I think in the context of the studies that we've done, we also showed that there was no impact on resistance. Okay. So in the 5 versus 10 day study, we looked at them over a 1-year period. Every time they got an ear infection, we treat them with 5 or 10 days. And there was no increased resistance on the 10-day group.
Resistance based upon?
Nasopharyngeal colonization.
I see, okay.
Nasopharyngeal colonization with pneumococci or beta-lactamase-producing H. influenza that were pneumococci with an higher MI, intermediate or highly resistant to penicillin. So that was shocking. I thought there would be more resistance, but there wasn't.
Do we see any resolution to this 18-year drought of new antibiotics? I mean, we see sometimes in popular media, concern about antibiotic resistance and the bacteria are outstripping our ability to innovate and to develop new antimicrobials. Is there anything on the horizon in regards to antimicrobial therapy that might be able to strike a common ground, or a middle ground in terms of duration of therapy? Some parents and children, as we know, are more difficult to get medication into than others. Is there anything that on your radar screen that might allow this to be shortened or modified in the future?
So we are working on a redevelopment of an antimicrobial, of amoxicillin clavulanate, not with the goal of inventing a new antibiotic. We're trying to decrease adverse event profiles. Mm-hmm. The most effective antibiotic, amoxicillin clavulanate, causes a high proportion of children having diarrhea, high proportion of children babies having diaper dermatitis, mm-hmm. and parents discontinue treatment in many instances, so they stop for a few days and then restart, which is the worst thing we can do. But they're having adverse events, so mm-hmm. we shouldn't blame them for that. What we did is we reduced the clavulanate to less than half of what's on the current clavulanate, and we were able to accomplish, from the pharmacokinetic standpoint, to get levels of what's called the area under the curve, the amount of antibiotic the baby is exposed to, that are only 5% less. Even though we decreased 55% the amount of clavulanate, we only got 5% reduction of the area under the curve, with about a third in the reduction of the diarrhea, reduction of diaper dermatitis, and a 90% reduction in discontinuation of study medication. So we had a meeting with the Food and Drug Administration, who they're really interested in using the minimum amount of drug that is needed to accomplish the goal. And the efficacy was even a little bit better on the open label study that we did. So we're going to do a formal trial for approval of that drug and labeling with FDA. So we hope to have at least one new antibiotic in the years to come on this.
Fantastic. That sounds like a win-win. Well, I want to say thank you very much for joining us today. We were a delightful conversation.
Thank you
for joining us.
Thank you.
Thank you.